Good morning. Let me share my screen.
Yeah. It's visible.
Respected Chairperson Dr. Narasimha sir, delegates and friends. At the outset, I should thank Fever Foundation for bringing the focus back onto temperature and fever. Fever and body temperature is one of the oldest vital signs, but often neglected. We have so much of interest on respiratory rate, blood pressure, or pulse rate, but we have neglected temperature in our clinical practice. It is one of the least studied or well-developed science as far as vital signs are concerned. There have been a lot of technological improvements in terms of recording, analyzing, and interpreting, but temperature analysis is lagging behind very much. Fever is an adaptive innate immune response. Whenever there is a threat by infectious agents or non-infectious agents, the innate immune response is the one which comes into the forefront immediately. It is a non-specific one, but that's one of the first responder. And when the initial phase of the immune response starts, fever is part of that response, and this innate immune system is activated, but to a certain level. Uncontrolled, it will produce a lot of damage. So body knows how to control it. So after the initial quick response, the innate response comes to a plateau, and then it's well under control. So this coordinated, adapted phase of immune response is very important, both in terms of the fever and also the variety of biochemical changes that happen in the body. The idea is to contain and control the infection or the other non-infectious agents. But once in a while, this adaptive response can go out of control, and that becomes maladaptive response. Especially when there is infectious agent, body has a very good control over the adaptive process, and there is a limit to which the temperature goes up, and that remains within that physiological range for well-controlled, orchestrated changes that can control the temperature. Once in a while, this will go out of control, and this maladaptive response will give rise to significant inflammatory changes, including body temperature, and that's when it becomes deleterious to the host. In biological system, everything is in a delicate balance. We have the balance between coagulation and anticoagulation. We have got balance between osteoblasts and osteoclasts. There's a very delicate balance between inflammation and anti-inflammation. There is also a delicate balance between mitotic and apoptotic changes. Similarly, as far as fever is concerned, there is a delicate balance between adaptive, protective fever response and maladaptive, destructive hyperpyrexia. So what should be a friend within the normal range of temperature becomes a foe once it goes beyond the tipping balance, and that's when it becomes a maladaptive, deleterious response, and that's where we have to be very aggressively intervening and controlling the temperature. Within that physiological range, often we don't have to unnecessarily bring down the temperature, but then beyond certain limit, when that protective reflex itself becomes destructive, we need to be aggressive and bring down the body temperature so that further harm is not done. Hypothermia versus fever is always a confusing term. Fever is a pyrogen-mediated rise in hypothalamic set point, because of which the body temperature goes up subsequently. So here, the pyrogen is the one mainly from the infections, which sets the hypothalamic set point. And once the hypothalamus has set the point, all the changes happening in the body try to increase the temperature to reach that set point. That is fever. In hypothermia, it is temperature set point is not altered. The thalamic alteration of set point doesn't occur, but the temperature is generated either by the external mechanisms or because of internal mechanisms. Here, the thalamus is not changing the set point; it is remaining wherever it is. Ultimately, both are dangerous. Whether it is pyrogen-induced set point changes, or whether it's because of the external or internal temperature generation, ultimately the high temperature is deleterious, and whatever be the mechanism, it is dangerous. But understanding the mechanism is important because treatment is different. Hyperpyrexia is one where the fever response goes beyond the limit, beyond certain limit, which is quite damaging to the body. Hyperpyrexia and hyperthermia are not the same, although most of the literature, there is some overlap between the two, because ultimately when a patient comes with high temperature, it is difficult to see whether the hypothalamic set point is changed or not. But whatever it is, hyperpyrexia is a term which is reserved for uncontrolled febrile response due to pyrogen which goes beyond a certain level. In infections, as I've told you already, it rarely goes beyond 106. But arbitrary level of 106 is defined as hyperpyrexia because it is expected that a lot of enzymatic changes will occur beyond 106 degree Fahrenheit. There is no unanimity as to what should be the cutoff level for hyperpyrexia. Many authors would define it as more than 105, or many others would define it as more than 106 degree Fahrenheit, which is about 41 degrees centigrade. And that seems to be the generally accepted level of hyperpyrexia. But there is another functional definition also. When the authors feel that the arbitrary number may not be appropriate and the temperature at which there is damage to the body could vary from person to person from time to time. And that's why one of these old articles mentions that as a state, the hyperpyrexia is a state in which the internal temperature of the body is so high as to interfere with the physiological mechanisms which normally regulate the body temperature. It could happen at 106. It could happen earlier also in certain individuals. So according to this author, it should be functional definition, and in clinical practice, it is a matter of medical judgment. We cannot wait for the magical number of 106 to initiate treatment. Whenever in our clinical judgment, we feel that this temperature is deleterious to the host, we have to intervene and using all our available methods. Let's see what happens in when the temperature goes up and why should it goes up? Why should it go up? It starts with the thalamic set point when from the normal level, the thalamus is set at a very high level. Now the body wants to generate temperature to reach that level, whether it's a core temperature or the surface or the shell temperature. Ultimately, the body wants to reach that set point. How does it reach? It reaches mainly by shivering and all other available physiological mechanisms through which the temperature is generated. So when the temperature is generated by mechanisms like shivering, which is very, very bothersome for the patient and also for the metabolic system, the core temperature goes up first, then surface temperature gradually goes up to catch up with that set point. And once the set point is reached, then the shivering has come down. But in between, if you see this graph closely, in the initial phases, the surface temperature or the shell temperature is close near normal, whereas core temperature has already gone up. So if you record the temperature on the skin surface, you'll realize that this patient hardly has any fever, but in fact, the core temperature has already reached a very high level. When we go for recording of the temperatures, we should make sure that we check the core temperature, because ultimately what matters for the host is the core temperature, not the surface temperature, not the shell temperature. And the shivering is proportional to the set point and surface temperature gradient. If the surface temperature is kept arbitrarily low and the set point is at very high level, then there will be a lot of shivering, because ultimately the body will go by its set point, not the surface temperature. That is why artificial cooling of the surface temperature may not give the desired results. In fact, when the surface is cooled by artificial measures and set point is set at the same level, the gap is too much, and this will be whenever the gap is high, the shivering will be more, and that ultimately results in increased core temperature. So this is a paradox which we should keep in mind. Cooling the surface alone without reducing set point does not yield a desired result. In fact, it could be counterproductive because it leads to a lot of shivering and other mechanisms which generate more heat. Shivering is not tolerated by the host, nor the metabolic system. Shivering has both high metabolic cost and discomfort compared to a steady state of the body temperature. If the shivering is not inhibited by external cooling, there can be increased oxygen demand, and there can also be dangerous rise in the core temperature. That's why cooling without reducing the set point will not yield much of a result while handling patients with hyperpyrexia. And when we talk about hyperpyrexia, it's always the core temperature, not the surface temperature. So surface temperature can vary greatly, as I've showed in the previous graph. It can lag behind the core temperature for a sufficient enough long period of time, and during that period, if we go only by the surface temperature, we will miss dangerous hyperpyrexia. The ideal sites for measuring the core temperature are tympanic sites or rectal measurements. Oral may be inaccurate at high temperatures. In the usual temperature range of mild moderate fever, oral sublingual recording is appropriate, but at a very high level of temperature, at the range of hyperpyrexia levels, there could be a significant lag in the oral temperature, and it may not give us the appropriate readings. That's why we have to measure core temperature either by the rectal measurement or the newly developed tympanic recordings. We have published a small study recently where we have compared the sublingual temperature and the tympanic temperature. What we found was that in steady state or even mild moderate temperatures, the difference is hardly about 0.5 degrees centigrade between the tympanic temperature and the oral temperature. But at the temperatures above 39 degrees centigrade, there was a significant lag, and the difference could be as high as 1.5 degrees centigrade, which means that if oral temperature is 39 degrees centigrade, which doesn't fit into the diagnosis of hyperpyrexia, the core already would have reached 41 degrees centigrade, that's 106 degrees Fahrenheit, and we will be missing a lot of cases of hyperpyrexia if we don't measure the core temperature. Another study which was reported earlier compared oral temperature and rectal temperature, and they also came to a similar conclusion. At high temperatures of more than 39 degrees centigrade, there is about 1.5 degrees centigrade difference between the oral temperature and the rectal temperature. So briefly, what it means is that whenever there is a doubt regarding hyperpyrexia, we should go for appropriate core temperature, either the tympanic or the rectal temperature recording. We also did another study to compare the conventional accelerated temperature recording and compared with the continuous 24-hour recording. And you can see here that when there is continuous temperature recording of the tympanic site, we can pick up a lot of spikes which are generally missed by the conventional recording shown in solid lines. So accelerated recordings done by the nurses in the fixed interval of 4 to 6 hours may miss significant episodes of the spikes of fever, and these spikes may be, matter a lot when there is the when the temperature reaches the threshold level of hyperpyrexia. In the same study, we also compared the difference between the peak temperature in the tympanic and accelerated recording. You can see that there is nearly about 1.5 degrees centigrade difference between the peak accelerated recording and the peak tympanic recording, confirming the fact that depending upon accelerated recording, intermittent recording, or even sublingual recording may not be appropriate while dealing with patients with a very high degree of temperature. Generally, we feel that infection is the major cause of hyperpyrexia. It is not. As I've already mentioned to you, the body knows how to handle the infection and the adaptive response, and it controls the adaptive response. A large number of hyperpyrexia is seen in cases like intracerebral hemorrhage, pontine hemorrhage, or thalamic involvement, or intracranial trauma. In terms of infections, malaria, tetanus, and other tropical fevers can produce hyperpyrexia. CNS infections, enteroviral infections, COVID-19 are notorious causes of hyperpyrexia. There are a variety of drugs starting with anesthetics and also drugs which act on the extrapyramidal system, which can produce hyperpyrexia. Among endocrine causes, thyrotoxic crisis is one of them which can produce hyperthermia. COVID-19 can produce hyperpyrexia either because of the cytokine storm or because of direct brain injury from the SARS-CoV-2 or because of the extensive vascular thrombosis. Whatever it is, there is high mortality due to COVID-19 induced hyperpyrexia, and unless we measure core temperature, we will miss many of these conditions. Hyperpyrexia is because of pyrogen-induced set point alteration. Hyperthermia is generally because of the external temperature or the temperature generated because of muscle spasm. But although definition-wise they look very interesting, clinical differentiation is not that easy. In a steady state of the high degree of temperature, it is very difficult to differentiate hyperpyrexia and hyperthermia. Both will give rise to very high body temperature, both will have dry skin, both will have complications because of high temperature. What we need to look at is the circumstances leading to high temperature, and this is what will give us the clue. Antipyretics do not reduce temperature in hyperthermia because antipyretics only act by reducing the set point of the hypothalamus, which is not altered in hyperthermia. So in hyperthermia, antipyretics generally do not produce much of a benefit, whereas physical measures reduce the temperature in both hyperpyrexia and hyperthermia. The symptoms could be fatigue, altered sensorium, hypotension, hemoconcentration, DIC, variety of organ damages. So all the symptoms are non-specific. It could be something like a SIRS. So multiple organ damages because of the extensive inflammatory changes, very non-specific. So we should have high index of suspicion to diagnose these cases. When do you suspect hyperpyrexia? Whenever there is a high temperature with the dry skin, and the exposed skin could be quite cold. So if the physician or the nurse just touch the patient with the hand and then talk about fever or febrile state, we'll be missing a lot of patients with hyperpyrexia. You just have to touch the unexposed area, then you realize that the patient is very hot, and this is where you must suspect hyperpyrexia. Very hot skin which is unexposed, cold skin over the forehead of the hands, and the skin is very dry, there's rapid shallow respiration, and this is when you suspect hyperpyrexia, and immediately confirm it by checking the core temperature either by rectal or tympanic temperature. Once you have diagnosed, the treatment is quite easy. In the sense, the principles of treatment are antipyretics and physical cooling. It is not either antipyretics or physical cooling. It is antipyretics and physical cooling. Physical measures will reduce the temperature by about 30 minutes, but antipyretics will have a slightly delayed but sustained effect. Only when it's combined, you see better results. To hasten the temperature loss, there should be enough fluids. So give liberal amount of oral and intravenous fluids. IV paracetamol is quite useful in reducing the as antipyretics. Other NSAIDs can also be used. Rectal route can also be tried for reducing temperature. Sponging with tepid water, not cold water. It lukewarm or temperature is required, because if there's cold water, it will lead to more vasospasm and more chills and more shivering and more temperature. That's why application of ice packs or cooling brackets, which were recommended earlier, are not recommended now, because they will be counterproductive in inducing vasospasm and more shivering and more temperature generation. Along with sponging, there should be exposure to breeze, use a fan or other modalities, because evaporation is a very good method of taking care of loss of temperature, and monitor the core temperature frequently. Cooling is mainly for hyperthermia. There the thermostat is not reset, so cooling is quite appropriate. But for hyperpyrexia, heat dissipation is important. So hyperpyrexia is treated with antipyretics and heat dissipation measures, mainly tepid sponging and fanning, and that will take care of the temperature by enhancing evaporation. IV paracetamol is to be used at the dose of 15 mg per kg over 15 minutes in 100 ml infusions. There are some cautions. Whenever there's decreased muscle mass, depleted glutathione source will be there, and there will be sudden toxicity. And same is the case if there is prolonged fasting or malnutrition. Be careful when a patient has got renal, hepatic, or cardiac impairment, and if there's dehydration or chronic alcohol intake, it can produce hypotension, it can produce infusion site reactions. Other close mimics of hyperpyrexia are drug-induced causes like anesthetic agents, and interestingly, many of the drugs which are used in extrapyramidal diseases, and more and more case reports are coming towards dyskinesia, hyperpyrexia syndrome, Parkinson hyperkinesia syndrome, serotonergic syndrome, neuromuscular syndrome. All of them are characterized by elevated core temperature beyond the threshold of 106 Fahrenheit, and aggressive treatment is required. Dyskinesia, hyperkinesia syndrome is seen when there is significant amount of dyskinesia and muscle spasm, and that can give rise to hyperpyrexia, can be treated with the dantrolene. Parkinson hyperpyrexia syndrome is another interesting condition. Here it is because of withdrawal of anti-Parkinson medications or stoppage of reduction in the dosage, and that can give rise to dangerous hyperpyrexia, and here the treatment is resumption of dopaminergic drugs. And most of the central hyperthermia can be treated with baclofen or bromocriptide, because they act at the central level, and the peripheral muscle spasm can be controlled with the dantrolene. In conclusion, hyperpyrexia is a maladaptive innate immune response system, and beyond certain threshold, which is arbitrarily defined as 160 degrees Fahrenheit, it is dangerous. There is direct damage and high metabolic cost to the host, direct damage to the organs and tissues, and high metabolic cost in terms of increased oxygen demand and more load on the cardiovascular system. And non-infectious causes are more important than infectious causes. And whenever we treat hyperpyrexia, in addition to the measures to reduce temperature, we should look into the underlying cause, because without treating underlying cause, you can't have long-lasting control of the temperature. Skin temperature, the shell temperature is not sufficient. We have to go and monitor the core temperature, and we'll be missing a lot of cases of hyperpyrexia if we go by measuring or observing the skin temperature only. Tympanic membrane is one emerging option, which is quite non-invasive, and it can measure continuously the core temperature, which is a challenge when there is rectal temperature. It's very difficult to monitor the rectal temperature continuously. Hyperthermia is much more dangerous than hyperpyrexia, and physical methods combined with antipyretics are the mainstay of treatment for hyperpyrexia. Thank you very much, and if there are any questions, I'll be happy to take them. Thank you once again.